All right, so session 19, this is our second to last session. Opioids and the older adult. Kurt went down 400 rabbit holes in this one, mostly just trying to prove that he isn't an older adult. So if everyone could put their videos on, that'd be awesome. And let us know if there's more than one person in your room. These are recorded. Still, there's free CME, all the things. Make sure you fill out the form that you will get in your email, or at the end of this, you will see it.
It's free.
It's not been funny for 5 years. All right. So yes, in 2 weeks, we are going to have the final Tuesday Echo. We are kind of going to base it on all the questions you've all had on your response, your CME forms. And so if there's anything specific that y'all want to let us know that you really, really, really want to hear about or want clarification on, or anything that from the past several months, email us, chat it in, because we want to make it kind of a good wrap up for all of you guys. Tomorrow on the Wednesday Echo, meth use disorder and buprenorphine management. So how do they kind of work together? And November 2nd, of course, don't forget Sam Quinones, the Sam Quinones. He gets the author of Dreamland and The Least of Us, like the most amazing books ever. So make sure you read those in general, just because they're that good. This is a big deal, guys. So much so that is not what I broke my leg jumping up and down on, but definitely was exciting when we found out. We are, of course, always here for you. You can text us, call us. You can reach Erin as well. So if there's anything that comes up or you want more information on, or you need help with, never hesitate. The online site. We have not submitted all the papers yet, but they are done, except for one thing. Guys, we finally finished this silly manual for the 3rd time. So stay tuned. That'll be there very, very, very shortly. You can also, register for the Wednesday Echoes. I was bad. We did not tape a podcast for this week. Darn, broken leg and stuff. We'll get there. Last week was another one of the sugar addictions, one that was much more entertaining and understandable, I think, is what the feedback we've gotten is. But that, of course, is how you get there. So Kurt's objectives today, y'all can read them, and apologies, Kurt's going to take over. If there are any questions throughout, please chat them in and we'll go from there.
This was actually quite fun. So what we're going to do today is talk a little bit about the things that describe that increase the risks for people and some of the aging processes. And again, before some of you came on, we were talking a little bit about what is an older adult. Most of the people would say 65 and above. I think there's a bunch of us on here that would say 70s, probably closer to the truth. But I think that 65 is generally what it's set at. So let's talk a little bit about prescribing opioids for older adults. And again, this was an interesting little paper I ran across that was kind of a guide to choosing and switching amongst them. And I think that as we look at prescriptions for opioids with patients that are older, again, we always want to look at that analgesic ladder, and we're always trying to use things that are potentially not going to, number one, cause other adverse events, but also things that aren't addicting. And often, too often, I think people in the past have gone to things such as opioids, especially in the older adult, which can be much more tragic. So again, the ladder, we want to do non-opioid things first. So why is it a concern? Well, we have to think about with older adults, and those of us on here are not included in this group as far as cognition and such, because we're all thinking so clearly today.
I'm just here to clarify everything Kurt said.
Yeah, that's right. But one of the things you have to think about it, when you get people in their 80 and their 90, and you're writing them prescriptions or you're talking about their care, cognition and their hearing and their vision can really make a difference on how the treatments you give them turn out. If they can't read the prescription well, if they didn't hear you and you didn't write it down, there's a lot of different things that can go wrong. And so we have to understand that in the older adults, things need to be printed out. Things need to be, nurses need to call and check. We need to make sure that they can accurately read what we're writing. And again, screening for dementia, because there are certainly times where patients just don't understand. So Keep that in mind. And so, again, medications can be taken incorrectly. They may not understand that one medication got discontinued and another one started. And how many times have we run across this where they kept taking a medication that had been stopped or supposedly stopped quite a while ago? So one of the other things to think about, and this will come up later with some of our cases, is that patients may also need assistance setting up their meds. And that can be a good thing and it can be a bad thing. And we'll talk about that in a bit. So some of the big issues, do the formulation and the dose of long-term opioids really contribute to the risk of adverse events in older adults? Well, until recently, there really wasn't a lot written about older adults. But what we do know is that we look at chronic non-cancer pain, it's very common, right? So it can be disabling. And if we look at it, 3 to 4% of adults receive these long-term opioids. Now, this is not older adults. This is all adults. 3 to 4% receive long-term opioid therapy. And actually, there's very, very good data that shows that patients that take the highest doses are actually the people that have the worst troubles. They have the largest number of adverse events. And if we look at of all the people that are taking opioids, 3% of those older adults, those people 65 and above, actually get doses that are 120 morphine equivalents or above. And again, that's in a range where we're going to see as we get higher, we're going to see a range of higher adverse events. There's very good data that shows that it is very much dose dependent as adverse events. And I think we saw a lot of that data come out with some of the stuff at the opioid work group, where the clear relationship between dose and adverse events for all people. But just recall, there is no safe dose of opioids. So why do older adults have more risk? Well, I think we all understand that things change as we get older. I haven't noticed any of those things changing, but I hear that things change. And one of the things that happens is that our kidney function, our liver function, our breathing can be different. And you keep smiling.
I'm just thinking of you when you run with your running partner who's far more young than you.
Yeah.
And you're like, they're trying to kill me.
She's making this stuff up. And so really this altered metabolism is really what contributes to these adverse outcomes. So people won't metabolize these things. The metabolites will build up. So we can have a lot of other problems as people age. Does it make a difference if a patient is on a long or a short-acting opioid as far as adverse events or risk? And the answer is very simple. It's yes. This definitely makes a difference, and it's something that you always need to be thinking about. If you look at kind of the initiation of these long-acting opioids in just the regular group, this is all comers, two times the risk of overdose compared with short-acting. And that, of course, is why a lot of the recommendations came out that we should never be starting with long-acting opioids. And it was really unclear now, until recently, until some studies were done with older people, whether or not this was true and how much worse it was with people over the age of 65. And this is actually a recent study regarding that particular thing, the dose and the opioids and the formulations in older people. And this was Monica Salker et al. It was a woman, Heather. And the cohort really actually included Medicare patients. Et al.
That's dementia, because we've reminded you of that 1,000 times.
Yes. And so they actually took Medicare patients that were older than 65. And this included all the patients who had chronic non-cancer pain. And what they did is they kind of measured their adverse outcomes, including whether or not they had respiratory depression associated with their opioids, whether they overdosed accidentally, and really they looked at all-cause mortality. So any reason that these patients died during the time they were on opioids, they compared them against people who were not on opioids. And the results of this was very clear that if you used long-acting opioids, whether with a short-acting one or with long-acting or both of them, your risk of overdose was much higher. And all-cause mortality as compared to people who are just on short-acting was, again, much higher. And so we have to really look at the long-actings as in the older crowd as really being a significant risk from both of those standpoints. Now, if we look at dose relationships, and we look at 20 to 50 and above 50 morphine equivalents a day as not really a big dose. And in fact, if you look at the state guidelines, you know, you're not supposed to be over 50 if you're on a benzodiazepine. And I think when I see a patient that's on 20 to 50, although I recently had somebody who ended up getting switched to Suboxone who was on 40, we really look at these doses as really so small that we wouldn't think that they would have a problem. But even at both of these levels, all-cause mortality, respiratory depression, and overdose are much higher than people who are on 20 morphine equivalents per day. So 20 milligrams of morphine a day or less is clearly safer than anything above that. And this is really consistent with all the studies that have come out in the last few years.
And this is just opioids, not including opioids with benzo.
Correct. This is just opioids alone. We'll talk about benzos in a minute.
Just making sure we're all on the same page.
So how about a dose relationship? You know, are the adverse events really related to how high we go? And there are people who advocate that if we have patients who are on 150 morphine equivalents and they've been stable for years, they're the legacy patients, that we should just let them be. And the reality in my world is that the higher the dose, the higher the adverse events. And if you look at the morphine equivalents over 100, they have a significantly higher odds of opioid respiratory depression than less. And again, we see dose dependence in just about everything as far as adverse events. This was Zedler et al. And so if we
still all,
I know I had to say that just to get you. And again, we talked about this, the cause, why are older adults having a little bit more trouble? It's that renal function, it's that liver function, and it's that inability to clear some of these that then will kind of pile up their metabolites, and then we have a problem. And just remember, just as review, there are some of the opioids that are more so cleared renally, and that'd be morphine, hydromorphone, or Dilaudid. And again, meperidine or Demerol, which we don't use, you don't see that used very often anymore. And if we look at the one that should be most often used if somebody is not able to renally clear it, the one to use would be oxycodone, okay? And one little aside here, if you've got somebody who's got liver insufficiency in the older group, really the things that you want to think about more are fentanyl and hydromorphone. And in that way, you avoid some of the issues that we would have that may cause adverse events. So how about the association of average daily morphine dose and falls? Because I think when we look at older adults, falls are well known to be a big problem as far as how long do people live after you break your hip or you have these other big accidents. And this is actually a study that was done by Stephanie Wang, or Huang. I'm not sure I can say her name that well. It's H-W-A-N-G. She actually did this as, she was a pharmacy person who did this as her PhD, as a PhD study. And what she did is she looked at adverse outcomes, especially with falls, as to whether or not these were a significant thing if they were on opioids. And we do know that falls, even without opioids, are the leading cause of fatal and non-fatal injuries in older adults, right? There's almost 3 million ER visits just associated with people falling, and hospitalizations and deaths, right? 27,000 deaths a year just from people falling down, like Heather did. She fell down, broke her ankle.
I didn't fall.
I had to just make that up. So if we look at the fall data from 2018, 27% of people who are older adults fell at least one time. Okay, 10% of these people were injured significantly. And so this is just in patients who are not on opioids. This is all comers, okay, on opioids or off. And so most often, I think what we've always looked at is how we prevent falls. And when we were in training, it was like avoiding having throw rugs in their house and all these ways that we could help older adults not fall in their home. But
let me tell you about throw rugs.
Yeah.
Crutches and throw rugs don't go well.
Yeah.
Or scooters.
That's good to know.
It is good to know.
I'll put more.
I definitely.
I'll put more in your house. Yeah. I'll drop a couple off. And so really, what about medication? You know, what can we do with people's medication, or do we put them on things that put them at higher risk? And specifically, how about opioids? Is there a big dose-related effect on falls when we put older people on this? And the answer is really yes, it does. We know that opioids overall cause more OD, but they're actually, until just this study, were no studies relating it to falls in older people. And so she did this rather interesting thing where they looked through 10 primary care clinics and went through their EMRs. And they really pulled out anybody who'd had more than 4 prescriptions a year. And then they looked at what their average morphine equivalent was for that day, for the days that they were on them, just to get an idea then if they fell, what are the dose levels that are going to make patients much higher risk for injury. And what they found was it's really pretty low, 37 morphine equivalents. So that would be like 10 of oxycodone, 2 or 3 times a day or 2.5 times a day, right? That's very little oxycodone. Those people had almost a 50% greater risk compared to people taking less than 37 morphine equivalents per day. So I think that to me, what is really important to understand is it doesn't take much of an opioid to make fall risk and the results of that fall significant. And of course, there's other different things that we give patients who are older. And if you remember from one of our previous talks about benzodiazepines and opioids, the people that are on the highest dose of opioids, interestingly, are more likely to be on a benzodiazepine. And in fact, they're more likely to be on a high dose of benzodiazepine. So we've got a super high risk group. And how does the co-prescribing affect falls and hip fractures? So the first study that was done was actually looking for association between these co-prescribing and people over 65 years of age. And what they did is they looked at 287 people who broke their hip, and they actually had almost 600 control patients. Most of the patients, of course, were women, 72%, and their mean age was actually 82, so older adults. And what they found was that patients who had actually taken opioids and benzodiazepines in the month prior had a 4 times higher risk of fall and hip fracture. And so co-prescribing is an enormous problem when we look at this, and especially if you know the data showing that people on the highest dose of opioids are most likely to be on benzos. So I think we need to really look at that. I think sometimes people talk about some of the things that we get on our state, on some of our state, what's the word, report card. Why is co-prescribing such a big problem? Well, it's a big problem because people fall as well, not just overdose, but falls. So this was a little study done on opioids and chronic pain in older adults and looking at falls and fractures and ED visits. And in fact, they did something that really showed that overlapping benzo and opioid prescriptions increase that odds of falling, much like the other study. And they actually did with 517 adults in a large private health system and VA system, kind of looking at the same thing that Stephanie looked at. And interestingly, when they took that group and they looked closely, 25% of them, or 127 people, were co-prescribed benzos and opioids, and showed very clearly that this was a group that was associated with much higher adverse outcomes. And they had 3 times the number of falls, pretty close to what our other study showed, and almost 1.5 times greater number of ER visits. So again, co-prescribing is not just an overdose risk, it's a fall risk. And we all know the studies that have shown that when you break your hip, what your risk of death is in that next couple of years is pretty significant.
50%.
It's high. And so one of the things we don't think about often when we're looking at somebody's chart and they're on opioids is, do they drink alcohol? And that's probably a question we should be asking a little bit more often, especially after you see the data and the patients who are taking opioids and how much they're drinking.
I think just with that, before you talk about it, just the fact that you just said you don't think we should ask more, as especially a newer provider, especially back in the day before did any kind of addiction stuff, I think it's uncomfortable to ask, like you ask a 70-year-old, well, how much are you drinking? And it just has this weird comfort thing with it that it's just uncomfortable to ask. And I think, what you're about to say is super important.
Yeah. And it's really about how you ask, right? I think that's really important. Or just suggesting that alcohol with the meds are on may be an issue.
Well, and I think sometimes older adults, some of them who maybe are in recovery, get offended, or even asking, you run the risk of an older person being offended by you asking about them drinking.
Yeah.
And
so the reality is that alcohol and opioids are frequently used together. And And in fact, alcohol probably contributes to a lot of the overdose deaths. And I think if you look at the data that, from the state, often alcohol is involved in other overdoses. Now, both of these things, both opioids and alcohol, are of course CNS depressants, and will decrease that or will increase that risk of respiratory depression. So one of the interesting things about this is there really until recently was not much research on this association, despite the fact that we know they do the same thing and can cause some similar troubles. Oops, there we go. And if you look at the majority of patients with OUD, they also have a chronic diagnosis of some kind. And if you review charts, as they did in this study, 23% of them also had a diagnosis of an alcohol use disorder. So if you look at patients with an opioid use disorder, a fourth of them actually have an alcohol use disorder, which again, one of the things we say all the time is, what's the best predictor of a use disorder? It's having another one. And so it's not uncommon that they will then have two. Kaiser Permanente actually did a study, and they looked at 11,000 patient charts of people that were on opioids, and they showed a very similar number, that about 12% had current alcohol use. And of course, it doesn't really quantify it, but literally, if you're talking 1 in 10 people has significant alcohol use, that's something that you should know if you have them on opioids.
And these are all older adults in these studies?
This one is not,
okay,
but we're going to talk about that. In a similar study, they actually have nearly 1,000 patients on chronic opioids. And they just did a survey to get an idea of how much people drank while they were on opioids. And I don't think the first number is all that exciting, because 36% of people had a drink in the last 30 days. That's not much, right? Maybe they had a drink in 30 days. I think that's something we would all go, well, you shouldn't do it, but that's not too bad. But if you add the last two bullet points there, it's 10% of people had more than 6 drinks, right? They had a time where they had more than 6, and 6% had more than 10 drinks while taking opioids, admitted to that. And so I think when you think about the risk of that, that is something that obviously you would want to take into account if you put somebody on chronic opioids. And especially when you look at from the other side, if you look at patients who have an alcohol use disorder, we look at these patients, they have pain. And so are these patients going to end up on opioids at some point? Because almost half in general are going to have some moderate to severe pain. And alcohol does numb the pain. I think we see that all the time where patients say, it's the only thing that really kind of takes the edge off my pain. So what makes alcohol a bigger issue in older adults? Well, it's really that changing physiology. We talked a little bit about that before, although it's a little bit different when we look at alcohol and what makes it an issue as far as with opioids. One of the things is that, older adults have typically less fat stores. And so they'll have a lot higher blood alcohol level with each drink. They tend to be having more troubles with their balance with each drink, because balance does seem to worsen with time anyway. And if you add a little alcohol to that, it can be a problem. They have much slower reaction times, and they may not drive as well. And so this can also lead to accidents. And of course, memory deficits. If they're drinking, they have some memory deficits. They don't remember if they previously took their opioids. They take a second dose. That's when we're going to have problems. And that's what helps kind of increase that alcohol-related harms. So how often is alcohol a concern in these older patients? Well, in some developed countries, there's been some studies that have shown that 90% of patients over 50 drink alcohol at some level. So 9 out of 10 people. So people over the age of 50 that you might start on a chronic opioid are drinking.
I love this study called Older Adults Over 50. How do you feel about that?
Well, I think that's inaccurate, but I'm just going to go with it. And a United Kingdom study showed that 20% of that group actually consumed hazardous levels. And that's very close to some of the other studies that we've seen, is that, they're probably drinking at risk, probably 4 or more drinks a day. There's actually an AMA study that was done here in this country that in the last 10 years, the group that's actually drinking more is actually the age over 65, and it's up 65% for that age group. So there is a trend that over the age of 65, alcohol intake is actually on the rise. And just understand that older adults, I mean, we wonder, how often is alcohol a problem? Older adults are actually hospitalized just as often or more from alcohol-related problems as they are heart disease. I just had a patient an hour ago. This this exact problem. He'd just been in the hospital for alcohol related thing, has no heart disease. So, you know, it's something that we bump into. So the bottom line is really, if somebody needs opioids, even if it's a short-term opioid prescription following a surgery
falling and breaking their hip,
you need to ask them what they're drinking and make sure they understand that there is increased risk and they should avoid it. So that co-use needs to be something we counsel them about. And we really need to screen for opioid use disorder, especially when they end up in the hospital. If they fall, if they overdose accidentally, those conversations need to be had.
I would think that this is also important then to document that you had that conversation. You did talk about their alcohol use. You know, you have to document risks and whatever, but to comment that you discussed the risk of co-use.
Yeah, I think that would be wise. So this is just something that I added just for fun. And then we're going to get to a few cases that talk about some of the things that can go wrong in older adults. And I just, you know, I went down a rabbit hole. I ran into this prescribing study that was actually done. And it's interesting because they actually did a study, and the guy's name was Doctor, if you can believe that.
Like the song.
Yeah. And so what they were looking at was opioid prescribing decreases after learning of a patient's fatal overdose. So basically what they did over a period of 12 months is during that period, if somebody was overdosed on opioids and died, they would actually send the provider a little warning letter from the medical examiner about prescribing, making sure they're prescribing safely, screening for OUD, and all these different things. And they had a control group of physicians that when their patients overdosed, they didn't send a letter. And what they found was that the doctors or providers that actually got the letter reduced their high intensity prescribing. They reduced how many opioid naive patients they received opioids out of their clinic, and they actually reduced the cumulative opioid intake. So they clearly learned from the experience and were looking much more closely at their prescribing. And really the takeaway of that is, it's like, don't wait for somebody to die to really look closely and thoughtfully at what you're prescribing. It's interesting that when something goes wrong, people do change things and they look much more closely at it. And I thought that was just an interesting little thing that they did. So we're going to do a couple of cases, unless anybody has any questions about.
Questions. What and who would be good to partner in hospital clinics to address opioid education and overdose prevention, like especially if we're talking older adults?
Yeah, that's a great question. You know, the problem is that I think in most, you know, it's like in our hospital, the big hospital, they actually have a team that comes around and talks about chemical dependency. And I suspect that most of the smaller hospitals aren't going to do that. I think often in the smaller communities, it's really up to us to really, you know, or the physicians that surrounding the hospitals to have those conversations. Yeah, you know, and what ages are highest risk for alcohol and opioid use? And I didn't come across anything that really said, you know, which group is more at risk. I can tell you, and I think Heather, you can maybe comment too. I rarely see somebody with an opioid use disorder that drinks significantly. It seems like they may drink some, but often when they stop their opioids, then they may increase their alcohol intake. And it doesn't seem like they're together as often.
And I think that's for, you know, the patient population we deal with now, who we're seeing for actual opioid use disorder. You know, if you think like back into a clinic situation, the people who were on chronic opioids, and I didn't have many, that's who, you know, seems more at risk. Because there is no known. I think once we've met people and have them on buprenorphine, there's very little alcohol intake.
Yeah. And I think too, if you think about, again, that 50 and over age group, if 9 out of 10 are drinking, I don't think that you're going to have a lot of people under the age of 50 on chronic opioids. So my hunch is it would be that 50 and above that are actually are using opioids and actually drinking as well. So
comment about, you know, that discharging the AVS, if you will, building this education into the discharge paperwork. I think that's always important, is just to get that information out there. I wonder if you quizzed all the people who got that, how many of them actually even read it or processed it. I think obviously it's important, so then you get the information out there and hopefully somebody in the family reads it.
Yeah.
Yeah.
Okay. Any other questions? So
now, do you get into the whole legacy patients?
I don't know if we're gonna. I don't think I really get into legacy patients.
So I'm going to bring it up really quickly then. So, one thing we always hear are these legacy patients, where a person, an older adult, has been on opioids chronic for non-cancer pain for, 20 years, 30 years, 40 years. And so, they might be 70 now, but they've been on it since they were 40, 50. And they're doing great. They've done well. They've never had a complication in 30 years. Why do something about it now? I think this is kind of that one thing we always hear. And at the state, other state people on here can say those are the people who come in and get upset. And you touched on it, but like the answer to that question.
Yeah, and I think that the reality is there's nobody on chronic opioids in my way of thinking that's not having a complication from it, because every one of them will have constipation. The men will have low testosterone, which is linked to all-cause mortality, fractures, all kinds of issues. And I think that, the higher the dose, the more adverse events, the falls. I don't see a good reason not to have a conversation with the patient about their opioids, no matter how long they're on. And the development of opioid use disorder can come after 20 years. I just had a patient last week who'd been on a relatively small dose of opioids for 20 years. And suddenly the prescriptions were lasting less and less long, and until suddenly she was in withdrawal and ended up in the emergency room. And so the development of the opioid use disorder is, these people are not immune to that. That's going to happen. And I think it would happen to any of us.
Well, and even aside from the opioid use disorder, I just think like what you talked about with the metabolism and all the other, our bodies change and different things break down differently. And so even if you've been on the same dose and been doing well, you're not throwing it into the same physiology as you did 20 years ago. And I think, especially with these numbers, like 37 morphine equivalents, I mean,
doesn't take much. Yeah. Again, that's 2 10 milligram oxy and then maybe a 5 milligram at bedtime. That's not much. And then we're getting increased falls. So these cases are actually real cases that we had in our clinic over time. That kind of illustrate the things that can go wrong in patients, both on long-term opioids and just patients in the older age group, and how sometimes how things can go wrong. And the first one we'll call case 1, family friend. Okay, this was a patient that was about 80 years old, and he had a history of chronic back pain. He was not taking that much hydrocodone. Again, this would be, he was taking just 4 of those. So he was taking 20 morphine equivalents of hydrocodone daily. So our nurse gets a phone call, and she said, hey, he needs a stronger pain medicine. His pain has been bad. And she identifies herself as saying that she's his nurse and arranging his med. And so the physician received this message, and to his credit said, hey, really, why don't we have him come in? And I believe our controlled substance care team nurse went down, talked to him, and said, we need to get a urine on him and kind of see what's going on as well. And at the visit, of course, the patient states he's taking his medication as prescribed. And so he comes in to see his doctor and gets a urine test done. And amazingly, the urine test is negative for hydrocodone. There is no hydrocodone in his urine whatsoever. And as we all know, that should be in there for a couple of days, and it was not. So more information was requested regarding his nurse. And as it turns out, she was a family friend who was volunteering to set up the patient's medication. And she was also on an opioid for chronic pain and signed a care plan in our clinic.
So the significance of this is that it's important because she is a patient in the clinic, had a care plan, so you can go dive into this. Yep. If this was not a patient in our clinic and did not have a care plan, there's nothing you can do.
So any thoughts on if you were faced with this situation, what would you do? You've got a patient that's on a care plan who is setting up somebody else's medication, and they've not had a urine drug screen in over a year.
And he does not have his meds in his urine.
No one wants to hazard a guess.
Well, obviously I shouldn't say obviously. I would be very suspicious that she is taking his hydrocodone or his oxycodone or hydrocodone.
Yeah, and so were we. It just seemed like, boy, this isn't a good thing going on here. So the family friend who she has a care plan. She's on chronic pain meds for her I think fibromyalgia or something similar. She was called in for a urine drug screen, and she was on oxycodone actually. And that's actually the medication that she requested for this elderly gentleman or this older adult. And so her urine was positive for oxycodone and also positive for hydrocodone, which she was not prescribed. So what would be our next step? Anybody thoughts on how we would handle a patient who's got the wrong? Are we the police? I guess that would be my question. What are we required to do? There's one thing we're required to do.
Who's his next of kin that is listed on his care plan?
Yeah, and the next of kin, and we're with him.
The daughter.
Yeah, came to the clinic. But again, we can't tell her anything about what's gone on at the clinic with this other patient. But is there anything we're required to do as a result of somebody not having their pain med in their urine and there's a concern?
Notify him.
Yeah, we need to notify somebody, and actually this would be something you have to report to social services, right? This would
be a vulnerable adult report.
Correct. So that's what we did. We found that she had that in her urine.
Well, we got it. She eventually acknowledged that she was taking his meds. So we can't just assume it, even though everything points to that.
But she did say yes.
She did say that yes. And you can still file a vulnerable adult report with the concern, and then they can look into it deeper. But
yep.
Yeah, I mean, you're going to want to try to find out about her, like if she will come clean to it or, acknowledge it, then she can get help. If she continues to deny it, now you're in a little touchier situation.
Yeah. And so again, we're not the police. Our job was both to understand that he needed his medicine, and she clearly had an issue, right? And so she admitted to taking it, and she voluntarily actually went to treatment. I think there were some consequences for her license, but I believe she got her license all taken care of and got back working and doing it. And so our concern was not to catch her or throw her in jail. Our concern was somebody had an opioid use disorder, and somebody was not getting their pain medication. So both those things were fixed, and she was taken care of. She actually did not go on Suboxone. She decided after going through treatment that she just didn't feel like she needed to, and so she never did. So that's case number 1. So case number 2, we call this one the cake lady. She's a very nice lady.
For anybody who's heard us present back in the day, you have heard this story.
Yeah, it's
probably multiple.
It's a great story because it involves cake. And so I walk into my office one day, and there's cake and there's some plates and forks. And I love cake. And so it was pretty clear.
You wrote it out.
Yeah, I eat cake, so I ate the cake. I had at least one piece, at least that's all I'm going to admit to. My office partner explains that every month his chronic pain patient comes. She's 75 and she's on some Percocet. She brings a cake to the office. And of course, he tells me how she says he's the best doctor she's ever had, blah, 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 all this stuff. So I'm like, well, this is cool. I mean, it's cake. Every month I'm going to have cake. Well, a week later, because we had a controlled substance care team and we had meetings frequently with the police on our task force, I get a call from the police and they say, by the way, we've got this problem. We just bought Percocet from a 75-year-old woman, and we don't want to put her in jail. We don't think that's really useful. And it turns out it's the same lady.
Because the police can tell you the names, you just can't tell them names.
Yep. And so
remember that.
I didn't tell them about the cake, but it was the same lady. And so we had the controlled substance care team nurse call her, and she called her in for a urine drug screen, and we talked to her physician, explained the issue, right? They don't want to put her in jail. They want her to help her and see what's going on. So what we find out is that when she comes in, her medicine is not in her urine. And of course she says to us, well, she's only taking it a couple times a week. And so either she's got a big stockpile, right? She admits she maybe's got a big stockpile at home, so she doesn't take them that often. So we just basically, talk to her. What would we do? her urine is negative. Anybody thoughts on what you do right there?
This is, sorry, Candy.
Oh, I was going to say, I'd be concerned that she is selling her drugs because she can't afford something in her life.
Wonderful point.
So, but what do you do? What do you do with her right now? Because she, again, comes monthly, but she says she only takes it 2 to 3 times a week. So in your head, you're thinking, well, then she must have a lot. But she has a good reason for having a negative urine, in essence, because she says she only takes it 2 to 3 times a week. So
but can you share with her that that you had received a police report that she was selling it? Because that's, you know,
we didn't want to scare her.
Yeah, and that's,
and your first point about, what is she buying with it? That's the key. And it's like, we just didn't, this was a nice lady. She was super nice. It was like, I think if we'd brought it to the police, we'd have scared her to death. And the police just wanted us to kind of solve this. So
I think one really quick thing that this point brings up, though, is when you're getting a urine drug screen, especially if anytime you get a urine drug screen is before you get the results. When you're getting it, ask the patient when they last took their med. Because if she said she took it that day or the day before, it should be there, and they're not suspecting anything at that point either. So it's always important to document when they took their med last.
Yeah. So really what we did is over the next couple of months, and she, she had some things where she had pain, but she had no real good documented pain generator. And so I wasn't honestly convinced she really needed the pain pills in the first place. But she continued to have negative urines when we'd randomly screened her. And so basically, after a while, the nurse just had the discussion with, it just didn't seem like she needed them. And why don't we try something else? We never did pill counts or anything. We just found a way to have a good conversation with her about her pain. And finally, she agreed that maybe she didn't need them. And we had that conversation that Candy had mentioned. It's like, well, what's going on? The social worker sat down with her, talked to her about her financial situation. She was really in a pinch. She was having trouble buying food. She was having trouble making all of her bills. And so the social worker worked pretty hard to get her signed up for things to make sure that she could cover her bills.
So she was prescribed opioids for a long time, just chronic pain, 75, and the provider just said, well, she's got pain, and so here's her meds.
Yeah.
And so it was one of those kind of legacy patients, if you will. And I mean, it never got brought up that law enforcement was ever involved. It's just, well, if you're not taking them every day, let's just cut back how many you're getting a month. And she, lived in an apartment with someone who was willing to buy them from her.
Yeah, right next door. Yeah. So really the moral of the story is that, she had another problem and we just needed to figure out what it was. And it really was financial. And that's why she kept coming back. And we were probably there another year or two, and she continued to do very well. Had no troubles, had no financial issues. So it was a nice way to resolve the issue without anybody really getting themselves in any kind of jam.
And it also speaks to having that good relationship in your clinic with the local law enforcement, with the local social services, with everything in your community, because law enforcement was able to call and know that we were going to help them deal with whatever situation without having to just throw this lady in jail. We were able to actually get to the bottom of it in a humane, patient-centered way.
Yeah. And actually, Cassandra asked why was she prescribed? You already kind of answered that, but it really was not clear. So the third one is an interesting patient of somebody that had chronic pain that had been on pain meds for a long time. And to be clear, this woman has serious medical problems, but she'd had a history of alcohol use disorder prior to all of this, and actually stopped drinking for quite some time. But she had a very clear indication for pain meds. This woman she, without a doubt, has the worst back I have ever seen in my career. And she's had multiple back surgeries. And eventually, before I left Little Falls, had her entire thoracic and lumbar spine, and eventually her cervical spine fused. I've never seen anybody get this kind of surgery. And she was taking over 100 morphine equivalents per day. And she presented to our ER unconscious, brought by ambulance. She'd been Narcaned, no change in her status. The ED staff removed her clothes and pills fell out of her bra, literally out of her bra. They were identified by the pharmacy as tramadol. And the husband was asked about these pills and then told staff that, in fact, he had a prescription for tramadol and didn't realize that she had been taking these. She was actually intubated and sent by helicopter to a regional hospital and put on a naloxone infusion. She didn't wake up till like the following day. So she had a pretty significant accidental overdose. And this woman was actually referred back to me by the hospital when she left that regional hospital for opioid use disorder. But when I saw her, she did not know that she was sent to me for an opioid use disorder. And so I would tell you that if you send people to addiction people, make sure you have the conversation with them. It's happened to me last week as well, where people come in thinking that I'm going to prescribe them more pain meds or I'm going to manage them so that they're safer. She was actually sent to me because they felt she had an opioid use disorder and thought maybe she should be on something else for her pain. So she clearly had an opioid use disorder. And in fact, we started her on Suboxone very shortly after that. And she continued to have tramadol in her urine. And as you all know, tramadol is not on the usual dip. You have to send that one out special. We continued to have conversations about it. And until her husband actually bought a safe and locked it up, we continued to have trouble with her popping some tramadol on top of her Suboxone. So beautifully controlled pain. She did well with the buprenorphine, except when she was having surgeries, which she had many. And I actually increased her right to the top. She was taking 24 milligrams the first couple of months, and we were breaking that up. So instead of taking 8 3 times a day, she was actually taking 4 6 times a day for the pain benefit of that. So for this woman, what was the biggest advantage of the buprenorphine versus the full agonist? Is it why would we switch her to that? What's the biggest advantage? Anybody got a hazard a guess here? Candy, you've been hot. I don't know.
Well, it seems like we're hearing more and more from you guys that buprenorphine has some pain management components to it that can be really effective. That's all I can think of.
Yeah, and compared to morphine, there are studies that show that its pain control is as good as morphine. Although most patients will try and tell you it's not as good, the studies, when it's blinded, it can be just as good. The other big advantages, yes, and Laura just popped it on there, decreased risk of accidental overdose. The ceiling effect of buprenorphine makes it so these patients don't get respiratory depression and die. And so for her, not only to protect her from the tramadol that she kept taking from her husband or anything else she might come across, but it also, that ceiling effect, she's just not going to get the respiratory depression, even if she overtakes the Suboxone, which she occasionally did. So I think both of those things are beautiful. It's pretty good pain control, and it's got a ceiling effect. So that's, I hope those cases were helpful. I think it just gives us some thought about, we can't just not ask questions in older adults who are on buprenorphine, or on opioids. We need to always be vigilant because it's their safety that we're worried about and the safety of the people around them. So that's the take home point. Heather, anything?
No, I'm still shocked because I didn't look through any of this prior, but with that low morphine equivalent, that's
with
crazy
falls
to me.
Yeah.
Well, the falls, and I mean, it is a 50% mortality within the first couple of years due to something.
Yeah. After a hip fracture.
So I just think that's stunning. And
yeah. All right. Any other questions before we let everybody go? Our second to last Tuesday Echo. Actually, it was one of my favorite talks. It was really, really fun to look at this information. Not because I'm an older adult, I'm 4 years from that, but I think that it was just super interesting.
That's so funny.
All right.
So yeah, if you have anything, again, if you specific topics, when you're filling out your survey for today, please let us know. And so we can make the last session extra fun for all y'all.
All right. Well, thanks everybody and have a good Tuesday. Tomorrow, remember, we have Cole coming on. He's a fabulous speaker. That's a great talk he's got. So we'll see you tomorrow.